recurrent lump over left anterior chest wall. So she is a 39-year-old female, presented with lump around 2.2 centimeter in upper and inner quadrant of left breast in 2018. Fine needle aspiration cytology revealed lipoma. So she underwent excisional biopsy on 30 August 2018, which histopathology revealed invasive ductal cell carcinoma grade 2. And pathological staging was T2, NX, and MX. Immunohistochemistry, triple negative. For further evaluation was done, it was ultrasonogram of both breast and axilla, where we found multifocal highly suspicious malignant lesions, 10.5 into 9.9 millimeter, and another one was 12 into 9.3 millimeter at 10 o'clock position on left breast with left axillary metastatic lymphadenopathy. And MRI of both breast was done, and it was diagnosed case of left breast postoperative lumpectomy state with accumulated exudates in supromedial region of left breast, with surrounding parenchymal infiltrations and mild thickening, dimpling of the skin was also found, and which suggested maybe postoperative regional inflammation, though absolute possibility of infiltrating residual neoplasm could not be ruled out. So she underwent modified radical mastectomy of left breast on 9th October 2018, and histopathology report revealed surrounding breast tissue including the small foci of invasive ductal cell carcinoma grade 2. Margin was uninvolved, lymph node also uninvolved. So pathological staging was PTX, N0, and MX. And she received 6 cycles of chemotherapy, which was completed from 15 November 2018 to 1st March 2019 with fluorouracil, epirubicin, cyclophosphamide, and docetaxel. There was no radiotherapy. She was on regular follow-up, and she developed mild lymphedema on left arm July 2019 and treated conservatively. And she noticed another painless lump on her left anterior chest wall on September 2020, which was gradually increasing in size, for which she came once again. And there was no history of fever, cough, hemoptysis, jaundice, bone pain, or headache. And none of her maternal family suffering from such type of disease or other malignancy. She was a regularly menstruating woman till November 2018. When she received first chemotherapy, she only menstruated once, and then she developed menopause. She regularly took OCP for 8 years, and she gave birth to her first child at 28 years old, and age of her last child is 7 years. On examination, we found that her right breast and axilla was normal, and left chest wall was healthy scar of previous modified radical mastectomy scar, and upper and lower flap, no abnormality was detected. There was 3 into 3 centimeter non-tender firm swelling, palpable deep to pectoralis major muscle, and there was no axillary lymphadenopathy. So this is her scar mark of previous modified radical mastectomy, and here is the lump. An investigation profile. So on 17th November, we did ultrasonogram of both breasts, and recurrent malignant lesions 15.3 into 7.1 millimeter, and 16.7 into 11.3 millimeter in left upper chest wall due to pectoralis major muscle at 1 o'clock position. And also ultrasound-guided core biopsy was done, which revealed invasive ductal carcinoma grade 2. And on November 2020, also mammography of right breast also done. Normal right breast and axillary lymph nodes was found. On 24th November, immunohistochemistry report was revealed ER/PR and HER2 negative. Ki-67 labeling index was 12% reactive for the tumor cells. This is our mammogram of right breast, which is normal. And on 5th December, bone scintigraphy was done, which was also normal. On 21st December, non-contrast CT scan of chest. It was unremarkable operation bed, normal chest sciagram. This is the CT scan. And questions needed to be discussed about what will be the further evaluation options, what will be the treatment option, and what is the prognosis of her disease with this type of disease presentation, and which previous treatment algorithm would have prevented such recurrence. Thank you all for patience hearing.
Thank you, Dr. Jannat, for your excellent presentation. Over to you, Dizon, sir.
Sure. Thank you so much. So can I just get some clarification? So she had a modified radical mastectomy back in September, as well as lymph node surgery. Is that correct?
Yes, sir.
Okay. And she had no disease in the lymph nodes back in 2018, even though you say the ultrasound that was done prior to surgery showed metastatic adenopathy in the axilla.
No, sir. There was no lymph nodes were clear. There was no metastasis in the histopathology report. There were a number of lymph nodes were 9. All came negative for the metastasis.
Okay. And in terms of the pathologic stage, why is she TX?
She was previously there was lumpectomy, but on MRM specimen on modified specimen contain no focal. They contain foci of tumor cells, but not obvious lump was there. No obvious lump was there.
So she was probably from her prior excisional biopsy though. She was probably a T2. Is that right? Because it was a 2 centimeter lesion.
Small foci of invasive ductal cell carcinoma, grade 2. This one, that's right. This TX.
Okay. All right. No, I mean, I think the chemotherapy that was delivered up front was appropriate for sure. She got an anthracycline as well as a taxane. Quite frankly, we still like to give the anthracycline in triple negative disease, although, as reasonable an option might have been docetaxel Cytoxan. I think in younger women, we tend to give the anthracycline as well. At this point, there's no evidence that she has metastatic disease. You've done a complete comprehensive workup. I'd say I would want to hear from our surgeons, granted it's deep into the muscle. So you're talking about a major resection to get this out, but I would wonder about some maximizing local regional therapy to try to get this out. Certainly one could utilize chemotherapy up front in sort of a quote neoadjuvant setting to maximize local control, but I'm wondering if the surgery options would change even if we were able to shrink this down given the location of the disease. So I wonder if there's a surgeon on the call who can comment on that.
Yes, if there is a only single focus recurrence involving the chest wall muscle, and if clinical examination and MRI shows that this is resectable, I wish we can go for a surgery. So after surgical resection, to have better locoregional control, I would suggest that the patient should undergo locoregional radiotherapy as well, as she was not given any radiation earlier.
Okay.
And what has been told that whether she can go again for some sort of chemotherapy followed by surgery, yes, that can be another option if she responds well, and surgery may take a better result of local control. But whatever may be, she will need surgery, chemotherapy that will be followed by locoregional radiation. Yes, always there is an option for a single focus or a localized oligometastatic diseases.
Yeah, I mean, I would agree. I think, I do think a local approach would serve her well. At this point, the question would be, assuming you were able to do the surgery, is there a role for chemotherapy right now? One could argue, given regional recurrence, you could hold off on the chemotherapy while you're maximizing local control and reserve the chemotherapy for evidence of metastatic disease. That's an opinion. A very reasonable separate opinion would be to do exactly like Professor Sayeed just said, do the local control and then do quote adjuvant chemotherapy again, in which case, I probably would not use an anthracycline again. I would probably go back to use a taxane. I think you could even do something like a platinum and a taxane, given its triple negative disease. I think she has options. I wonder, Professor Sayeed, if you did pre-operative radiation, given the location of the disease, would that make your surgery easier?
No, I think after doing surgery, after radiation is always difficult because the tissues, they're very difficult to heal. They create problems. So they should have, if there is a plan like this to have a better control, surgery should be first, then it will be followed by radiation.
Definitely, there was a role of radiotherapy, which is must needed, particularly in triple negative breast cancer. Rajesh sir, what is your comment regarding particularly this case, and also in case of triple negative breast cancer, when a node is negative, but should we still consider radiotherapy or not? Rajesh Balakrishnan sir.
Thanks, Arunangshu. What my suggestion would be like is this patient, when she had a excision biopsy which has come as triple negative, my first thought would have been to offer her systemic treatment upfront and then take her for surgery rather than going up with surgery followed by a systemic adjuvant. Maybe I would have preferred to give a neoadjuvant chemotherapy upfront, follow it up with surgery, and then to go for RT. So that would have been my sequence for this patient. For any patient, the young female who was 39 years old with triple negative breast cancer, which is the most aggressive type. So that would have been my treatment plan from the beginning, because she was positive, nodes are positive on the imaging, ultrasound to see for her. So that would have been my thought, because she already had a node which is clinically significant on the ultrasound, which says that she might have a systemic disease. So I would have preferred to start with the neoadjuvant chemotherapy, follow it up with surgery. That would be my first thought. But anyhow, this has been given, the chemotherapy, whatever is given is appropriate. Maybe the chemotherapy schedule, what we currently follow in a hospital now is we give a combination of docetaxel with cyclophosphamide, alternate with epirubicin and cisplatin. Each one give 4 cycles each. So we get a total of 8 cycles, which will be followed up with surgery. We get a pathological complete response of near about 60% with this combination of chemotherapy regimen. And another thing is for any patient who is 40 years and any patient who is less than 50 with IDC and a T2 disease, most of the normograms which say for triple negative say that they will have a nodal positivity rate of 35 to 40%. So which will definitely put my thing into like the patient would have definitely benefited with RT, local RT. So there has been multiple trials which says that for triple negative early stage, it is better to offer them RT, but the benefit might be small. One randomized trial was done in Canada. So what they did was they took patients who had BCT for early breast cancer, TNBC, and then the other arm was MRM. What they found was the disease-free survival was 96% versus 85%, and overall survival was almost 10% more when you compare with the other arm where the RT was not given. So that is one thing, and there are multiple Chinese trials are there which definitely shows that there is benefit with RT when you add along with chemotherapy for early triple negative breast cancer. So I would have definitely thought that this patient had a role of RT maybe after the completion of chemotherapy. That is one thing. And currently when you see if there is a lesion which is there very close to the chest wall, if it is excisable, that is the best. You need to excise and follow it up with a chest wall RT. And maybe I will treat the nodal diseases, the original nodes also I will be including my RT portal. Maybe a chest wall, supraclav and axilla, I will be including all in the radiation portal.
Yes.
Thank you, Rajesh sir. We will take quick comments from Qamruzzaman sir.
These are very young cases with the triple negative breast cancer. Definitely, as in the patient, as the lot imaging systems has been done, that shows there is no other nodal involvements. But since we had to go for a long time with the multimodal approaches like surgery, chemotherapy, radiation therapy, so it is an expensive one. Before that, I think we can have a PET scan, so we can exclude the nodal involvements, and then we can go for the resection of the primary recurrent lesions followed by radiation therapy. Then along with that, we can go for chemotherapies, because we know the triple negative breast cancer usually comes within 1 or 2 years with the recurrence, and prognosis is not that much good. That is all.
Salim Reza sir.
Thanks, Dr. Arunangshu. So as the disease is basically, it was the, first of all, axial lymphadenopathy, but after surgery, there is no metastatic axial lymph nodes. In this stage, as the patient recurs in short period of time, so what Professor Qamruzzaman mentioned here, I should say for the staging workup, we should do the PET scan. If the PET scan shows that is something in the agile lymph nodes, definitely we go for, first of all, neoadjuvant chemotherapy, which Professor Rajesh suggests. That is dosi and cyclophosphamide alternative to epirubicin and cisplatin, as it is reproductive breast cancers. Then go for surgery, then definitely go for radiotherapy. This is my opinion.